So this evening, we'll be looking at assault of health workers by patient relatives. I'm Dr. Itibu Ibrahim from CMDA Gwagwalada. It's such a privilege to take this topic. I know there are senior colleagues here who will do great justice to it, so I feel privileged to be taking it. Thank you. So we'll be looking at it under this outline. Introduction will look like at the forms of violence, epidemiology, the risk factors, possibly consequences, prevention, and what should be our perspective as healthcare workers, as Christian healthcare workers. Okay. Workplace violence is becoming a common and frequent occurrence in the healthcare setting. It is an issue which we put our fragile health system more in danger, as it contributes to and has similar effects to the mass exodus of healthcare workers in Nigeria. It is not just a Nigerian problem, earlier I say, but it's that of, it has a global magnitude. So it doesn't just affect us, it's happening all over the world. It affects all healthcare workers in all healthcare settings. So whether a doctor, a nurse, a pharmacist, a lab scientist, even the revenue clerks in our hospital or some of the administrative staff. It happens to anybody that happens to work within the healthcare setting. And these settings may be private, may be public, it may be those where we have like small PHCs, big teaching hospitals, anywhere that healthcare is being delivered, whether it's during home care or, at such points, or even ambulances, all healthcare settings where healthcare is being delivered. It seemed to have been neglected in the past, but then it's coming to the front burners in recent time. And it's something that must be addressed holistically by all parties involved. I used to say, those of us in the healthcare system, the patients and their relatives that come into the healthcare system, the government and state at large. So it's defined as incidents where staff are abused, threatened, or assaulted in circumstances related to their work, including committing to or from work, involving an explicit or implicit challenge to their safety, well-being, or health. This was adopted from the European Commission. So it comes in different forms and in different ways. As long as it's related to the workplace or related to our trying to carry out our duty in the healthcare setting, then it becomes workplace violence in the healthcare, in healthcare. And of particular note, we should take note of committing to or from work. We know we have had instances in the past that because people are healthcare workers on their way, to work, they are being kidnapped and all that. So it's not just within while you're in the hospital or in the health facility, but as long as when it happens, it's related to your work, then that can be considered as workplace violence in healthcare. I'm sure we have seen many of these happenings. I think of recent, just around the 25th, there was this news on a man attacking an Ondo doctor, a nurse with cutlass over the son's death. And you know that these are frequent things that we see on the news. This is just one of such. And I'm sure since the beginning of this year till now, we've seen several, from the one in Delta and so many others that we see in our facilities. So what are the types or forms of workplace violence? So it can be physical, it can be psychological. Physical, when it involves the use of physical force against another person or group, but result in physical, sexual, or psychological harm. So when we are talking about assault, it strictly actually refers to physical harm. But however, we wouldn't have dealt much with it if we do not talk about psychological, because psychological forms a large chunk of it. The burden of psychological is quite huge, and they tend to also overlap. And you can find out you could find out that psychological a violence that has started as being psychological could progress to become physical. So when we are talking of physical, it involves beating, kicking, slapping, stabbing, shooting, biting, pinching, among others. And then psychological is intentional use of power, including threat of physical force against another person or group that can result in harm to physical, mental, spiritual, moral, or social development. It includes verbal abuse, bullying, mobbing, harassment, threats, and the likes. So, what is the distribution of workplace violence in terms of who is affected, and where they are affected? So, according to sorry about this. Okay, so who are the perpetrators of workplace violence? One, any person who commits an act or acts of violence or engages in violent behavior can be described as a perpetrator. And this perpetrator could be employer, management, or superior, could be colleagues, could be patients, their relatives or attendants, and others such as terrorist group. But particularly this evening, we'll be focusing on relatives of the patients. Then who are the victims? So any person who is the object of act of violence or violent behavior, as described previously, would be considered a victim. Although all professions in the health sector are potentially at high risk of workplace violence, some appear to be at special risk. So an example would be nurses and ambulance staff who are said to be extremely at high risk, doctors, support and technical staff at high risk, and all other allied professionals are said to be at risk. So according to the WHO, between 8 to 38% of healthcare workers suffer physical violence at some point in their career, and mostly perpetrated by patients and visitors. So this is the world average. It ranges from 8 to 38% for physical violence. So according to the result of a systematic review and meta-analysis involving about 253 studies with a large number of participants, it said that up to 60% of healthcare workers have experienced violence, and about 42.5% of this was non-physical, while 24.4% was physical in the past year. So among the non-physical, verbal abuse accounted for a large portion of about 58%. It's said to be the most common form of non-physical violence, followed by threats and sexual harassment. And this is said to differ greatly from country to country, study location, practice settings, work schedules, and occupation, as we would see later. In this same review, it was said that workplace violence against healthcare workers is high, especially in Asia and North American countries, in psychiatric and emergency department settings and among nurses and physicians. Even though you will understand with me why we might maybe not be ranking here because of our poor data, or the fact that it's maybe underreported in our setting, and maybe if they were all reported, might be among those with high prevalence. In another review of 14 studies, it was found that workplace violence had a prevalence of 58.7%, physical had 20.8%, verbal 66.8%, and sexual harassment 10.5%. Just to look at figure from elsewhere, in Brazil, they did an online survey to cover before and during the pandemic, and they found out that it didn't vary much. The incidence of violence before the COVID-19 was 60%, but during the that period, it dropped a bit to 57.9%, approximately 58%. And only 37.7% say that their workplace offers some sort of procedure or routine to report acts of violence. And verbal violence was said to be the most reported among these participants. So look at some studies at home. In South West Nigeria, there was a study done, particularly I think it was in Ogbomosho, and the highest prevalence was among the nurses, which accounted for 53.5%, followed by doctors and dentists, 21.5%. In the last year preceding the study, it was said that 57.4% out of doctors experienced it, while 59.2% of nurses also experienced it, compared to 62% among other professionals in the healthcare setting. From that particular study, 46.1% was due to patient, while 49.5%, which is, as we can see, more than that of the patient, were from the patient relatives. And the commonest were verbal, with 64.6%, and physical, 35.6%. So, and these violent acts were said to occur majorly in accident and emergency and in outpatient clinics. So I would like to quote a study from Southeast Nigeria, from where our prof was one of the authors of this particular study. With the prevalence of workplace bullying was, this was a study done among nurses. So the prevalence of workplace bullying was 82.6%. The behavior was observed on most days over 6 months period preceding the study, including gossiping, backbiting, excessive workload without supervision, failure to respect privacy, intimidation, humiliation in front of even patients, and then unfair allocation of job and posting. And the main perpetrators were said to be senior nurses. Then female nurses were identified as the main perpetrators and targets. And the reported impact of workplace bullying among nurses included anger. Some of them, the consequences that resulted was anger, intention to travel because they feel there'll be better condition out there. Some were anxious, then there was frustration and strained social relationships. So on the 9th of January 2023, there was a publication in the Punch newspaper by NAD, which revealed that no fewer than 345 incidents of violence against Nigerian doctors were reported in the year 2022. 74% of these attacks required medical attention, and 15% were said to be life-threatening. That was just in 2022. So what are the risk factors and the things that could lead to this workplace violence in the healthcare setting? We can look at it in terms of health system factors, individual household factors, and the government or state factors. That's a way to look at it. You know, when we are talking about inavailability of resources, poor working condition, and all that, that would relate more to the health system. But when we are talking about things that have to do with the individuals, the patient relatives, the doctor, or healthcare worker on duty, those factors are related to them as individuals. Then the government, talk about political will, financing of the healthcare system, and the likes. Well, broadly speaking, we could also classify into intrinsic factors, patient factors, case-oriented factors, hospital administrative and system factors, and the legal factors. So the Factors that are intrinsic to the healthcare worker: poor communication skills, personality traits, poor social skills, poor skill in conflict resolution, impatient or unempathic approach to patient management. Talking about poor communication skills, many a times as healthcare workers, when we are faced with challenges or management of a patient, we tend to be so heroic at times that we forget to carry patients and their relatives along. A patient comes with advanced cancer, advanced condition, who has maybe gone to several places and exhausted resources and finally reaching you. After history taking, your examinations and all that, at every point, this patient or patient relative should be carried along with the condition of the patient, such that it is not surprising. It won't be so surprising or so sudden for them when an adverse event occurs. Particularly in my mind, I remember as a house officer in one of the general hospitals here in Abuja, my consultant in pediatrics did something that was that has left a mark on my mind. Every time while we are managing the pediatric patient, there are times she would just call a family conference, even though she had a community medicine background. She will call a conference of the parents and explain to them, this is the situation of your child, this is what your child has, this is how far we can go, we hope for the best, but these are the possibilities. And most times when she had called that conference and prepared their mind, it's almost certain that in the next few hours or in the next day or two, we might lose that child. And it happens again and again. And I wonder, how does she know? But then, because these parents are being carried along, it's likely not to come too sudden to them, even though they might be grieved. Then poor personal traits. Some people may be generally aggressive or have some kind of traits that does not make them relate well with other people. Understanding our social context, even the way you greet and receive people, could actually go a long way. Then when these conflicts even arise, the way you go about managing it as a healthcare worker would go a long way. The patient-related factors, like I said earlier, most of our patients have poor health-seeking behavior, and then the delay presentation. By the time they are coming with advanced disease, or their condition is actually so bad. And then they come into the healthcare setting hoping for a miracle with unrealistic expectations. And so when they come that way and it's not met, this tends to make them aggressive. According to the Occupational Safety and Health Administration, which used 2013 Bureau of Labor Statistics report, says that workplace violence from patients requiring days absent from work represented 80% of cases of workplace violence. So, and then for some people, like I said, just as in the healthcare worker, the patients themselves could have aggressive traits, or people that are aggressive. And so that might lead to workplace violence. Then there are some cases, acute cases, those ones that are usually present in the emergencies, EPU, A&E, are more likely to result into workplace violence. The thing is that more often than not, these cases bear inherent time-bound consequences, and should there be delay of any sort in their management, they might be lost. So prone areas include pediatric setting, emergency setting, and the likes, like I've said earlier. So for the healthcare system factors that result in violence being maintained on health workers by patient relatives, it includes all hospital institutions should have like basic protocols of reception, admission, and guidelines peculiar to them. And most times these protocols are met with resistance when patients or their relatives, come into the health setting. At times they come in and you redirect them. Okay, this is not the starting point. First of all, you need to, go open a folder, do this and that before you get seen. And for some people, they could just flare up just by that direction. So there are also cases of limited resources. We know that both man and material resources are limited, and we're not strangers to this. Most commonly, we say lack of bed space, we have to be referred, we can't take you in, delayed retrieval of laboratory results, absence of point of care testing materials, or even the basic things such as the IV fluids, not being available, or and other consumables. This can result in workplace violence in the healthcare setting. Even this management or systems inability to recognize situations and identify their risk factors have continued to contribute to the rising cases of workplace violence in the work setting. Poor reporting, monitoring, and evaluation. You find out that usually in the wards, there are registers in order to take note of these incidents, but many people don't tend to report. And then some people, they tell you that when they report, nothing is being done about it. And so the next time it happens, they'll bother not to even report. And then when these things are being reported, who is monitoring it? How is it being evaluated? How can we tell? Is there a trend? Is it decreasing? Is it increasing? What is the description of this issue? I'm sure that many hospitals may not be able to provide this. Then absence of a redressal system, such that when somebody reports, this person gets a quick and urgent, addresser of the problem and gets justice. I've talked about delayed investigations, poor security frameworks. For many places, they'll tell you that, okay, when you're coming into the hospital gate, you see a security man. Aside that, you might not see as many. And once there is violence, before they get from their post to the place of the violence, it takes some time, and sometimes something really terrible would have happened. Then poor workplace organization. In many of our stations, you find out that when they come in fact, even you as a doctor, when you have a relative who is being admitted, you find out that there's a lot of moving around. You're directed, okay, you pay here, you get your folder, you move to this point, to that point, and you find out that there's a lot of working. And at a certain point, when the person gets to the next point of delivery, he might just flare up, he's tired, he's worked up. And the healthcare worker at that point too, who has been bombarded by work from morning, may also be tired and worn out. And so angers, emotions flare up and violence may result. Poor support for healthcare workers. If find out that many health workers lack training in conflict management, they are not trained, and then they are not counseled about how to go about it when things happen. Or even when it happens to them, they are not properly counseled to manage the consequences that this workplace violence, has on them. So, and this could further result into more workplace violence. And when people even report, at times the way the report is being treated in a non-confidential manner, it might predispose the victim to more harm. And so the victim might not want to pursue it. Others include bad media reportage, lack of respect for health workers in the society. Then the legal framework also has its problem. The law, which should be referenced and guide the activities of every registered institution, is often scarcely represented, as its position in either delayed or even denied due to unnecessary bottlenecks fueled by bureaucratic processes and sadly corruption. At times, some people will go far as, okay, reporting the violence, seek prosecution, or some kind of compensation and all that. But I find out that these cases are so drawn out that people get worn out and get tired. And so the perpetrator doesn't get punished, gets emboldened to do more another time, while the victim gets intimidated and might feel that there is no need to report, as it puts me more at risk of harm, and nothing is going to be done about it either way. So why should I report? So, and also relevant stakeholders who ought to uphold and ensure compliance with the law do not do so committedly. And eventually, the silence that follows such cases often becomes louder than the events that occasioned them in the first place. So doctors, patients, hospitals alike do not have a uniform code of conduct that guides their interactions and expectations concerning duties and mannerism. And this forms the bedrock upon which many of these workplace violences occur. So when a patient comes into the hospital, when their relatives come into the hospital, they should know this is how you behave here. If you behave out of place here, you will be sent out. If you're a relative, you do not behave yourself, this is what will happen. As a healthcare worker, this is how you talk to them, how you receive them, and how you treat them. So if these things, if they are clear, guide of their expectations, it might also help, to reduce this violence. But where they are lacking, then it's a milieu for this workplace violence to occur. So sorry, I'll just quickly run us to, we're almost out of time. So from other publications, found that the female gender, being single, time of the shift, most people say, especially night shifts, then location of the duty post, like I've said, emergency, outpatient, those places are more prone to it. From the statistics I referred to earlier, the publication in NAD, it was said that 65% of workplace violence was caused by patient deaths. 56% of the cases were caused by patients not being attended to promptly because of the high workload. 41% said it was due to poor communication. 28% inadequate security and surveillance system. Then 26% lack of facilities and drugs. 24% patient intake capacity is overwhelmed. And then 23% is due to the personality of the perpetrator. So we can see that many of these factors actually come to play in the setting of workplace violence in healthcare. So what are the consequences of this violence? When a healthcare worker is being attacked, whether psychologically or verbally, it leaves an effect on this healthcare worker. This can range from absenteeism from work. We've had cases of physical violence where a healthcare worker had to be hospitalized, even on ICU admission, had to be absent from work for days, and many at their lives were being threatened, and so it leads to absenteeism from work. Can also cause anxiety in the healthcare worker. Dealing with the workload and having to deal with this workplace violence can actually be tiresome. And for many of us, it creates fear, because we've had instances where colleagues have been, in some instances where colleagues have died. We had instances where patient relatives move around with weapons, maybe within the hospital, looking for a particular healthcare worker because they have something against him or her as a result of their management. It has resulted also in low esteem among the healthcare workers, even loss of concentration, stress. Many of us are beginning to tire out with the job, dissatisfaction, being able to help people, to get them better, to help humanity. People are getting tired of it. It's the dissatisfaction that should have come necessarily from being one of those offering hope to humanity is now diminishing. Then increased cost of healthcare. For a health worker who has to leave work is a cost. For a health worker who has to get treated because of violence, it comes at a cost. Then even the mass exodus of our healthcare workers to other parts of the world. Some feel that, okay, maybe if I live here, it is better out there. And so they decide to leave the country or intend to leave the country. So prevention, I'll just quickly run through it. So one, interventions to prevent violence against healthcare workers in non-emergency settings focus on strategies to better manage violent patients and high-risk visitors. That's the main focus when it is happening in non-emergency or non-conflict setting. But that's a bit different from when it is happening in conflict setting, like we have in the north, east, or other places where you have conflicts, unrest, insurgencies, and the like. So one, to recognize violence incidents and identify the risk of violence and take measures to improve work organization. This will include ensuring optimal staffing level, working time, supportive work teams, and improved working condition. Prevent staff from working alone and minimize patient waiting time. We find out that because of the high workload, because of this patient waiting for a long time to see the patient, because this doctor is tired, because of the long shift, or the nurse or other healthcare workers are tired, that is actually creates room for workplace violence, or the likelihood of workplace violence. Provide timely information to patients and family to reduce stress. Especially when patients come in, like I said earlier, when you have prepared their mind ahead, even when these patients die, it reduces the likelihood of violence during their grieving moment. But when they are not prepared, they are likely to be more violent. Then restrict movement, public movement in the facility, alert security personnel if violence is threatened. To provide security measures, which will include good lighting, security cameras, alarm, panic buttons, emergency signaling, security escorts where needed, and then protection of valuables. Then prepare and support the healthcare worker. This will include training them in conflict resolution, managing assaults, provide counseling to recognize the danger of violent behavior, and assistance to change the conduct or attitude in a case where the healthcare worker might be the problem. Then to maintain physical fitness and emotional stability of the healthcare worker too, or where it is noticed that the relative or patient coming in has such conditions, to be managed properly. Other measures include training us on soft skills like breaking of bad news, how to approach them, creation of emergency protocol and evacuation plan in case of a major violence. As much as we want to be heroic and do our best, when we find out the situation is getting violent, it is better to look for the closest exits and take your leave and make sure you report. Then restriction of number of attendants or relatives per patient. This has been said to be a factor. You find out that one patient is coming in and there are 20 more people following him or her to the hospital, choking up the already overcrowded facility and also causing trouble. So it would be good to restrict them. Posting armed security personnel, maybe at entrances of the wards, and other strategic places like the pay point. Our resident seminar room is close to the pay point in my facility, and you find out that we have not less than 1 or 2 cases of violence every day. You hear shouting, at the healthcare, the revenue clerk there and all that. So, and I'm sure if we have this security personnel posted there, it might reduce it. Then mandatory registration of all visitors to the reception. Okay, these are other strategies that can be used. Also, educating the public could be very important. The stakeholders, need to be aware. The patients, their relatives, they need to be educated. The public needs to be educated. The journalists, media houses, they need to be educated so that they can have a clear overview of what is involved, such that they don't paint the health system in the bad light. Worthy of note is the framework for of framework guideline for addressing workplace violence in the health setting, which is the collaboration of the ILO, ICN, WHO, and PSI, which would be good to take a look at. And there's also some kind of protocol for reporting by NAD in a case where that is for the doctors and where they encounter workplace violence. So what should be our perspective as Christian healthcare workers? One, we must understand that we are ministers and representatives of Christ in our workplace. We must be compassionate and empathic. We must speak kindly, and we must be competent and knowledgeable. We must pray and ask God for guidance, because at times we need Him to, we need to pray to give us guidance, to be strategic in managing situations, and also to even prevent such situations from taking place. We must comply with hospital policies, and then we must be as wise as serpent and gentle as dove in taking care of this. In delivering this healthcare, when our lives are threatened, we should know measures to take. We should report such that they do not occur again. At times, many people just say, I'll just leave it to God, and He will take care of it. At times, it's good that we report. As we pray about it, as we let God take control of the justice, we should also report them such that we're able to know the pattern, we're able to describe it accurately, and so be able to prepare solutions. In conclusion, violence against healthcare workers is unacceptable. It has not only a negative impact on the psychological and physical well-being of the healthcare staff, but also affects their job motivation. As a consequence, this violence compromises the quality of care and puts the healthcare provision at risk. It leads to immense financial loss in the health sector, and joint efforts by all concerned is required to curb this menace. Thank you so much. These are my references.
I will go to Dr. Ifeyinwa Mamilo. So, I believe you've had huge experience working in the health system in Nigeria. So, have you at any point in time been intimidated or assaulted on duty? And what was the experience like? And how did you manage that experience?
Thank you, everybody. Thank you, our sister Etubi, for the presentation, and you're welcome again. In fact, the experience I want to share was even as a consultant. You will imagine that if a consultant is there, you would the consultant will not be assaulted or will not experience a workplace violence and all of that. But this time it was I was in the clinic and I was seeing a patient, a sickle cell patient, and the mother was there, but the mother excused us, and I was asking the young man some questions and he was giving me the answers. And then there was some clarification that I needed from the mother. So when she came in, I asked her the question and she answered, and I said, but the young man said so, and you are coming to say something else. And then she said, doctor, if you don't want to listen to me, you get out. And I'm like, really? And she was like, yes, that this is how you've been asking me, because, sickle cell clinic is a clinic that they come all the time. So it's not like it's a one-off thing. So somehow we have engagements and contact with these patients on a regular basis. So the lady started saying, this is how the last time I came, you asked me this same question and I told you, is it that your brain, you're not putting it inside your brain? Why are you asking me this question all the time? And then she flared up and she was cursing and shouting. And some people came and she was saying that, because I said, Ma, please, is it possible for you to keep quiet? Or if you want, is it possible for you to leave the clinic? And she said, come and push me. If you try me, I will, and she went on and on. Now, what did I do? I was calm because I needed to take charge of the situation. So, but when I saw that she was, well, even the way she was shouting, some people had to gather in the clinic and then they were telling her, Ma, it's enough and all of that. Don't do this and all of that. So what did I do? First off, I got up. Immediately, she started shouting and started moving towards the door. Secondly, I was calm. I didn't have to engage in a banter with her, because I think sometimes when we engage in banters with with patient's relative or something, it worsens the situation. So when people came and she was the one shouting and jumping, they were wondering, is she okay? And then, of course, the security came and then they calmed the situation. But I was calm and I was moving towards the door. And of course, for me, it was to run away because we had something similar that a man came with knives and threatened people in the emergency pediatric units in the same hospital. So the point I'm making was that I was calm and I needed to be calm, because if I entered into that altercation with her, it would have worsened the situation. Then secondly, I was moving towards the door, and if possible, I could have called for help, like ran out and maybe called people, because the truth is you need to be alive. Well, she's a woman, but some people come with weapons and all of that to the hospital. And the first thing is that you need to be alive first to tell the story before you begin, other things happen. So even before then, we had made a rule that when a patient is shouting or something, start going towards the door and start finding your way first, and then call security, call for help, and always be calm. Ensure that you are not in an altercation with a patient. That's what happened to me, and I was calm. Then surprisingly, what happened again was that the next time she came to the sickle cell clinic, I was the one who was to see her. And her son was very, very ill this time. And that illness had a connection with the last thing I was asking her that last time. So by the time she came and opened the door and saw me, unfortunately, there was no other doctor. She moved back like, I can't do this woman again. And I went to the door and said, please come and sit down. And she came and sat down very humbly. And, we went through the motions, and then I saw the child and I admitted the child. During that admission, she actually apologized and said, doctor, if not that something about, she was sorry, she overreacted, something was worrying her that day and all of that, and that the way I managed her, that it really, really whatevered her. She was touched. She went home and she was regretting why she acted in that manner. So that's my experience. I'm hoping that I've answered that question, and I'm hoping that something has gone out from the experience. Thank you.
Thank you so much, Ma. Thank you so much for that. What institute that can help curb this menace of assault on the health workers? And yes. So what are the steps we could take, Ma? Over to you, Ma.
Okay, thank you so much, sir. Good evening once again, senior colleagues on the call, and thank you, Ma, for your sharing your experience. Okay, practically, like we know, resources are scarce, both human and material, anywhere, and that's the situation we find ourselves here, more so in those of us that are in resource plus settings. So, many of us as healthcare workers were involved in management, and so as much as is within our power, we should ensure that adequate number of healthcare workers are employed to reduce the workload on each individual healthcare worker. Also, the shifts and management, of shift for the healthcare worker should also be looked at and worked on. And peradventure, one finds oneself in that setting where, okay, some things are not provided for, you're overworked and all that. Then one has to learn to manage one's emotion. When you're off duty, try to take off the stress. Try to work on your own self so that you also don't develop problem in the process. And say you're met in an emergency with such a situation where they come with a child who is so ill or somebody with an advanced condition. From the beginning, carry the patient and their relatives along. It's practically to carry them along. See, this is what we have here. This is what we have. Please, you may need to go out to get this while I'm still trying to attend to your patient, because some of them believe that when you ask them to go out and get something, maybe you're just going to abandon their patient and go on to other things. Okay, this is what is provided for. This is what you would need to get. This is this patient's present condition. These are the likely outcome, but we are going to put in our best. Because what happens most times when we don't communicate is that they have so much expectation, high hopes, such unrealistic expectation that something, maybe somebody with an advanced cancer or something comes in. And so because you've not been carrying them along, in the minds of the relatives or other attendants, they may feel, oh, this person is going to get better. So they run around all the tests and all the things you ask them to get, they run around, they get it, they do all they need to do, only to find out that their patients won't make it, or they lose their patients. And then they are aggrieved, they are frustrated. And so learning to carry them along, because at providing some of these resources is out of your reach as a healthcare worker. But then when we carry them along, when we explain to them practically, and then try, to let them know, to give them insight into the situation at every point. We should not think that they don't understand. Even when they don't understand, explain it in layman terms. Let them understand. This is what we are facing. This is what we have as our disposal. This is what we can do. This is what may likely happen. Carry them along at every point. So when that is done, they are less likely to result, into violence. So I would say practically, those are the things that we can do at those points. And then for the resources available, to make efficient use of them. To make efficient use of them. To get the best you can get for the patient at that time, and let them know. But it's when we play heroic and we just do all the work, you're actually working hard, you're doing all you can. But when you don't carry them along and there's an adverse outcome, they turn on you. They turn on you because they are the face of the healthcare, with all the frustration of going up and down, having spent so much money out there, seeking healthcare in other places, coming late and all that. They turn it all on you. And so you must explain at every point of the way. I hope I've been able to answer you. Thank you.
Thank you so much, Ma, for that. Dr. Grace Bernard Asadu, can take your question.
Okay, thank you very much, the moderator. Thank you, Dr. Oniku, for this very lucid presentation. It was well done. Well done. So mine is not a question. Mine is more or less like a comment or an addition. So I understand this is CMDA gathering and all that. Yes. So I'm also in the public health sphere, and I want to just make an addition to words to everything Dr. Oniku has said. Maybe she must have mentioned it during the course of the lecture, because I actually came in logged in late, and for some time network was quite unstable. So aside like taking cognizance of some of these things, from the patient's factor and other things like communication, having a good communication and all that, I believe there's something the management of the facility should do. And maybe I know every facility or almost every facility has a resident doctors association and even a consultant, the MDCAN association too. So if these associations can actually put it up to the management, all right, for them to take the necessary or put in place the necessary policies that should be on ground, I believe some of these things will be curbed, because the patient, the assault from patient relatives is not just something to be taken lightly. In as much as, yes, there could be some factors, but you still find out that even when you communicate, you do some of the things, some of these things still go ahead to happen. And maybe because some of the patient relatives maybe haven't seen anything done to others that have committed such assaults before, somehow they kind of get away with it. All right, and it keeps worsening. So the associations in the facility, like the MDCAN, the ARD, the NAD, should actually put it onto the management or bring it onto the management for them to put the necessary checks. More like committing, like there should be signages, okay, at the entrance to the ward, to those very common areas that patients would have to go through, all right? And in my center, for instance, last year we had, it was actually becoming prevalent in my center last year. So one of the things we did, I was the vice president in my center then. And then I know I actually suggested something which somehow started working out. We had to commit, like add an addendum to the file of every patient. More like if you're coming in, you will have to sign an undertaking, your relative, either you or your relative will have to sign an undertaking. And what's that? It's more like saying that the undertaking commits you to the fact that if you are not going to be committing, you're not going to be touching any health worker, be it a doctor, a nurse, or whoever. If you're aggrieved by anything, there are numbers for you to call. Now, if you're found liable, you'll be punished. And when you sign that, that means you've agreed to those terms. So that when you go contrary to the terms, then you are punished accordingly. And we noticed that some of these things started, it didn't take it off completely, but it actually made it calm down a bit. And we're kind of enjoying seeming peace in my facility. So aside all these things, like in addition to all these things Dr. Oniku has said, trying to protect ourselves and, even being empathic to the patient, yes, empathetic to the patient, we should actually still make sure our management puts in place those things they should put in place.
All right, thank you so much. Thank you, Ma. We'll take Dr. Emeka Numa. Just 2 minutes, you can give us your input or you ask your question. Thank you. Hands up.
All right. Good evening, everyone. Good evening to my teachers and senior colleagues in the house. Thank you for the expository teaching. I just want to ask, some of the times we notice that these issues are between maybe other health workers and the patients, or the non-medical staff like the security or the cleaners and the patients. And as Christian doctors, I just want to ask, what role do we have to play in suing for peace when occurrences like this happen that do not involve us? Should we just fold our hands and walk away and keep quiet while these things happen? Or is there something we can do in our little way to bring peace among health workers and non-health workers in our service to our patients? Thank you.
All right, Dr. Ebuka Ugu, I don't know if you can help us with maybe an input on that.
Okay, Well, I think what I can say is that bystander reporting is crucial, and it's actually a quite standard practice globally and even locally, be it for verbal assault, be it for sexual harassment, be it for physical assault. Bystander reporting is crucial, especially when the abuse is psychological and verbal. The person in the eye of the storm may have lost agency to maybe start a reporting process. So it's important that if you witness such as a bystander, please go ahead and report. If the violence has not escalated to the point where you can physically intervene, you can do that while you have alerted security, whose job it is to intervene. So I think as Christians, we should never keep quiet as any form of injustice, be it a supervisor and a student, and someone else is observing it. And if you are the bystander, please make sure you do something, at least intervene or report to the authorities. Thank you very much.
Thank you so much, sir. We'll take the last question from Dr. Yetunji Sorian. So, sir, you can ask your question.
Yeah, good day, everybody. It's not really a question, it's just a short comment. I want to thank the National Secretary at CMDA and the presenter, Dr. Tubi Ibrahim, for this enlightening presentation, and the Secretary for creating the platform for this to happen in response to being sensitive to what is going on in the society. That's why we are there, to make a difference. I just want to point out one or two things quickly. The aspect of reporting have been emphasized throughout the presentation, but the point I want to make is not enough to report. So many reports have been made. If no action is taken, the root cause of that particular incident will continue to recur and it will propagate and worsen. So in that regard, I think every institution establishment should have a team, a quality assurance team, because customer focus is one of the 12 quality system essential. You need to engage with your clients, our customers, patients, we call them, in our own setting, but they are all clients and they are customers. They need to be engaged. Information flow is very important throughout the process. Openness, transparency. Research has been done in the US here where I am, that have shown that communication line, if it is open and transparent, it goes along. Even when there are sincere cases where there have been sincere medical error and negligence that led to such altercations, that transparency and openness has a huge impact on dousing the tension. And most of the time, those at the receiving end do not go the line of litigation when they see that transparency, empathy, empathic response, transparency, and openness is key. Communication is key. So there must be a team that, when these things are reported, look at all these things, apart from training, you need to do a root cause analysis, and our health workers need to be trained when you are faced with what are the remedial action. Remedial action is not the same thing as corrective action. Remedial action are the immediate steps you take to douse the tension. Corrective action can only be taken after a proper root cause analysis is done to identify the root cause, and then you now develop corrective action to eliminate that root cause so that to prevent recurrence. That is when you have done, full justice to it. And the last thing on that, the best way to go actually is to generate preventive action. Preventive action, the action has not called, we want to preempt it, don't want such incidents. So that comes from that team that has been set up, like the quality assurance team or customer focus team, looking at all the data available, the report that have been generated from the incidents and complaint log. Every establishment should have such incident and complaint log. I should encourage staff to to report. So they look at that and generate trends and look at preventive action that can be taken to even prevent occurrence in the first place. So that is just my contribution. That is not enough to report. Action must be taken. Root cause analysis must be done to identify the exact root cause of those incidents, so that you are not just cutting the surface, scratching the surface, while it's like an iceberg that has a more massive part covered up underneath the water. You are just seeing the tip of the iceberg. So kudos to the Secretariat and all the presenters and contributors. God bless you all.
Thank you so much. God bless you, sir. Nigeria, Professor Chima Onoka is online. If he has any input on the topic.
Okay, I think I was asked to round up or so. It's been it's been a beautiful 1 hour plus. I think the content has been so rich. There is, and especially with what Dr. Shonyo just added. I mean, and then there were lots of things that Dr. Prof. Sifanyona kept dropping, very insightful things as well. And it really looks like something we need to take forward, especially because, you know, the one major slide that Dr. Etub Ibrahim raised was the risk factors. There was just a 20-something% that was about the behavior or the personality of the person. Most of the other factors, or nearly all the other factors, are system problems. System, somebody not doing something well, or people not being equipped to even handle communication well, to handle engagement with people, or, you know, staff not being well scheduled. There are things that can actually be fixed, especially even the lead factor that is over 60%. And then, of course, all these issues of if reporting happens, how does it get followed up, the actions that get taken. So it looks like something that we need to actually come back again and have further discussions on and way forward and what kinds of interventions. It's for some of these reasons we have trainings like the saline process training, the things around whole person medicine, and we keep challenging people to learn more how to communicate better, and then to always also raise issues, especially those in management and all of those places, raise issues to help minimize the problem and mitigate the problem, really, and then to follow up and really take action. There are some things beyond us. Or now, if this kind of thing happens, what does the law enforcement agents, what do they do? But then we should begin with all the parts that we can control. Thank you very much. And I think it's been a great evening. Back to you to close us. Thank you.
Thank you so much, sir. Thank you everyone for staying. It's been over an hour. Just a little announcement. We will have such series every month. We discuss issues pertaining to our practice as doctors and health workers. So every month we have topics that we discuss, and definitely for the month of April, which we'll be entering tomorrow, I believe we'll have something rich for us. So just keep tuned in, and we'll always communicate. Please, for the slides, we'll make the slides available to all participants. You'll get it maybe via your email.
Father, we thank you for a wonderful time you've granted us. Thank you for these issues that you have inspired us to discuss so robustly today. Lord, we pray that you now give us the courage, the moral courage to act with wisdom and courage when confronted with these challenges, to stimulate our system, to stimulate our hospitals, to be the change as the salt you have placed us in this environment. And we commit the hearts of all our brethren who have suffered this sort of abuse. We ask that you inspire them, Lord, encourage them, comfort them, Lord, and re-energize them to render care for the whole man, spirit, soul, and body. We thank you for our panelists and all the attendees, Lord. We say, may all glory and honor be ascribed unto your name now and forever. In Jesus' almighty name we have prayed. Amen.
Amen. Amen.
Amen.
Amen.
Amen.